Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I'm a cardiologist. Let us learn something about atrial flutter today. Let's begin. The objectives of this presentation include a definition of atrial flutter and various types of atrial flutter, etiology, pathophysiology, history and physical examination, diagnostic tests, and various modalities of treatment for atrial flutter. Definition: atrial flutter is an atrial macro re-entry tachyarrhythmia where the atrial rate ranges between 250 to 350 beats per minute. You see the typical sawtooth appearance of the atrial activity with varying ventricular response. Epidemiology: atrial flutter incidence is approximately 200,000 new cases per year. The risk of developing atrial flutter goes considerably higher when we are dealing with patients with heart failure or patients with a chronic obstructive pulmonary disease. The risk of developing atrial flutter in patients with heart failure is 3.5 times higher than the normal population, and it is 1.9 times higher in patients with a chronic obstructive pulmonary disease. Classification of types of atrial flutter: there are two types of atrial flutter. Type 1, which is the typical atrial flutter with a rate ranging between 250 to 350 beats per minute. Then we have the atypical atrial flutter, or type 2, where the atrial rate ranges from 340 to 400 beats per minute. Let us look at some more insight into these two types of atrial flutter. Type 1 atrial flutter is the typical atrial flutter that we see in majority of the patients. The atrial flutter arises from the isthmus of the right atrium. It is a macro re-entry arrhythmia. It involves a slow, long pathway with an excitable gap. It forms a circuit within the right atrium along the lines of the tricuspid annulus. And most importantly, the impulse travels in a counterclockwise fashion through the right atrium and it propagates to the left atrium. The isthmus is the tissue between the inferior vena cava and the tricuspid annulus. Somewhere we have the inferior vena cava here, so it's somewhere between the inferior vena cava and the tricuspid annulus. Here is a typical type 1 atrial flutter. We have the waves directed towards the inferior leads on the electrocardiogram. In contrast to that, type 2 atrial flutter is atypical atrial flutter. It is not related to the isthmus of the right atrium. It lacks the excitable gap. It does not resemble the typical flutter waves, and we are going to look at some examples as how type 1 and type 2 atrial flutters differ in morphology, in addition to how they are originated and propagated. Talking about propagation, the type 2 atrial flutter waves go in a clockwise fashion from the right atrium to the left atrium and creates a circuit. This is a macro circuit, just like we see in patients with the type 1 atrial flutter. Most of the time, the intra-atrial short re-entrant circuit is very short in these patients, and it's generally related to surgical scars following cardiac surgery or irregular pulmonary veins, or it is related to disturbed mitral annulus. Here are some of the differences between type 1 atrial flutter and type 2 atrial flutter. As we can see, because of the counterclockwise movement of the electrical circuit, we see these waves directed towards the inferior leads, whereas in patients with the type 2 atrial flutter, the waves are directed downward, so we have a positive deflection in the atrial waves. To me, it's kind of very hard to say when you're looking at a sine wave which one is positive and which one is negative. But nonetheless, another important feature about type 2 atrial flutter is they don't resemble typical sawtooth appearance we see in patients with type 1 atrial flutter. On the electrocardiogram, of course, on most occasions, we are going to see this typical sawtooth appearance, which is at a rate of 300 beats per minute with a 2-to-1 conduction. That means the ventricular rate is approximately 150 per minute. However, if we see a 1-to-1 conduction, then we should always think about catecholamine excess, like in patients with heart failure and severe dyspnea or chronic obstructive pulmonary disease, or any evidence of other conditions such as hypotension or fever that can increase the catecholamine levels. It may also be related to parasympathetic withdrawal, and whenever we see a 1-to-1 conduction in an atrial flutter, that should trigger your mind to look for pre-excitation or WPW syndrome. Sometimes we may have to administer adenosine or other measures to bring out the flutter waves so that we can differentiate atrial flutter from other supraventricular arrhythmias. Here is an example of a typical atrial flutter with 2-to-1 conduction. The ventricular rate is approximately 150, so the atrial rate is 300 beats per minute. Even though we don't see typical sawtooth flutter waves, here we may be able to see some of them. The best way to bring out the sawtooth type of atrial flutter waves is to perform certain maneuvers, which I'm going to talk about in a minute. Here's an example of an atrial flutter with 1-to-1 conduction along with some degree of right bundle branch block aberration. Here the rate is approximately almost 260 per minute. And when we see this type of an electrocardiogram, the best option is to do direct shock. Whenever we are in doubt as to whether we are dealing with a supraventricular tachycardia, that is a sinus tachycardia, paroxysmal atrial tachycardia, or atrial flutter with 2-to-1 conduction, we can always give adenosine 6 milligrams IV push that will produce AB block, and then it may show the flutter waves. However, we should be aware that it can produce a prolonged ventricular asystole for several seconds before the rhythm is restored. Again, a Valsalva maneuver can be performed to bring about slowing of the heart rate, but it is generally not effective in patients with atrial flutter. Carotid sinus massage is another way to reduce the ventricular response rate so that we can see the hidden flutter waves. But before a carotid sinus massage is performed, we should always listen for any carotid bruit, because you don't want to disrupt any plaque and cause a stroke. And always remember that you and the nurse should not be doing the carotid massage at the same time, because you are going to decrease the cerebral circulation. Some of the underlying causes that are predisposed to atrial flutter or increase the frequency of atrial flutter include rheumatic heart disease, left ventricular dysfunction, sick sinus syndrome, chronic obstructive lung disease, and status post-coronary artery bypass surgery. Particularly post-bypass surgery, 30 to 40% of the patients develop atrial fibrillation in the immediate postoperative phase, and some of them may go on to develop atrial flutter. And as I already mentioned before, patients with left heart failure and chronic obstructive pulmonary disease have a much higher risk of developing atrial flutter compared to those without these underlying diseases. Another important point that we need to keep in mind is to make sure that we diagnose these underlying conditions, because most of the drugs that we use for control of rate or for control of rhythm have an adverse effect on the function of the heart and the lungs. Some of the lab tests that we need to perform or look for electrolyte imbalances such as hypokalemia, hypomagnesemia, or hypocalcemia. A pulmonary function test and thyroid function test will reveal any evidence of a significant obstructive airway disease or hyperthyroid state which can exacerbate atrial flutter presentation. A two-dimensional echocardiography is extremely important in identifying the left atrial size. The left atrial size determines how successful we will be in restoring the normal sinus rhythm after we have controlled their ventricular response rate. Again, evidence of a left heart failure can be an important point when we are considering anti-arrhythmic drugs for either control of rate or for conversion to sinus rhythm. Electrophysiological studies are not only diagnostic, but they also help us to treat these atrial flutter patients with ablation, where we have a pretty high rate of success. So the treatment goals include treating the underlying causes such as chronic obstructive pulmonary disease, congestive heart failure, and optimizing their medical situation. After that, we have control of ventricular rate both in an acute and in a chronic situation. Following that, conversion to sinus rhythm should always be attempted. Conversion to sinus rhythm should always be attempted, but we need to keep certain things in mind when we are talking about conversion to sinus rhythm, especially the presence of blood clots in the left atrium. Cardioversion can be done using anti-arrhythmic drugs or using electrical cardioversion, and we're going to talk about them. Ablation is the most definitive way to abolish the atrial flutter and maintain sinus rhythm. Again, talking about maintenance of sinus rhythm, we'll talk about what are the drugs that we need to keep these patients on in order to minimize the recurrence of atrial flutter. And finally, we're going to talk about the role of anticoagulants in the prevention of systemic embolization in the presence of atrial flutter or atrial fibrillation. Let's talk about control of rate. This is the first and the most immediate challenge when we are facing with a patient with the atrial flutter with 2-to-1 conduction, or if we are facing a patient with the atrial flutter with 1-to-1 conduction. The drugs that are available for controlling just simple ventricular rate include calcium channel blockers, beta blockers, digoxin, and amiodarone. And let's look at each one of these drugs. First of all, calcium channel blockers are contraindicated in patients with a left ventricular ejection fraction of less than 40%. That's the reason why I said echocardiogram is extremely important in identifying the presence of a heart failure, which will determine what type of drugs we are going to use for cardioversion or for maintenance of ventricular rate in the presence of atrial flutter or fibrillation. Beta blockers are very well tolerated by these patients. Beta blockers can be given as a metoprolol 5 milligrams IV every 5 minutes up to a maximum of 30 milligrams, and they can be switched to oral medication in a dose ranging from 25 to 100 milligrams twice daily. Even if we are using sustained release beta blockers, it is advisable to give them in divided doses so there is less side effect, and we should always watch for higher degrees of AB block since they are contraindicated in patients with type 2 or higher degree of conduction disturbances. Digoxin has been around for more than half a century. It has been successfully used in many situations in the past. It is also useful in controlling ventricular rate in patients, especially those who have left ventricular failure, and we'll talk about this in detail in a minute. Amiodarone can also be used for control of ventricular rate. However, IV amiodarone is not so successful in controlling the ventricular rate as it is when it is given orally, and even then it's going to take a long time for amiodarone to build up therapeutic levels. Digoxin is a useful drug in patients, especially with heart failure, in treating rapid ventricular response related to atrial flutter or atrial fibrillation. The loading dose of digoxin is 0.5 milligrams IV, followed by 0.25 milligrams every 4 to 6 hours to a maximum of 1 milligram loading dose. The maintenance dose includes digoxin 0.125 to 2.5 milligrams milligrams IV daily or by mouth. Then in patients with chronic renal failure, the dosage can be adjusted to 0.125 milligrams 3 times a week. The side effects of digitalis has received a lot of negative publicity in the media, but it is important to realize that digoxin is an important drug in controlling ventricular rate in patients with atrial flutter or fibrillation, where the rapid ventricular rate needs to be controlled in a short order. The best way to minimize the arrhythmogenic effects of digoxin is to keep the digoxin level below 0.9 nanograms per ml, and the digoxin level should always be measured 6 to 8 hours after the previous dose. In a number of cases, the digoxin levels are drawn within 4 hours after the morning dose, and invariably it is going to be high, and that is not a reliable index of the actual digoxin level. Calcium channel blockers are useful in controlling ventricular rate in patients with atrial flutter or fibrillation. Here is a red flag. If the left ventricular ejection fraction is less than 40%, we should avoid calcium channel blockers. Diltiazem can be given in a dose of 0.25 milligrams per kg IV bolus, followed by an infusion at 10 to 15 milligrams per hour. Another advantage of using diltiazem and verapamil in patients with chronic obstructive pulmonary disease is they do not cause bronchospasm like the beta blockers. Diltiazem can also be given orally in a dose ranging from 30 to 60 milligrams every 8 hours, or a sustained release tablet 60 to 180 milligrams per day. Similarly, verapamil can also be given intravenously in a dose ranging from 5 to 10 milligrams, and this could be followed by 40 to 80 milligrams every 8 hours by mouth, or a sustained release tablet 120 to 240 milligrams daily for control of ventricular rate in atrial flutter or fibrillation, and it is especially useful in patients with severe COPD who cannot tolerate beta blockers for any reason. Amiodarone is a class 3 anti-arrhythmic drug. It acts on the sodium, potassium, and calcium channel, but its predominant action is on the potassium channel, which prolongs the refractory period, the action potential. Amiodarone can be given intravenously in a dose of 150 milligrams of bolus. If that doesn't help, we can repeat a second dose with 300 milligrams. Amiodarone can be given orally as 400 milligram tablets 2 to 3 times a day, up to a maximum of 1600 milligrams per day. As the patient's condition improves, the dose can be reduced to 200 milligrams twice daily or even once daily. An important consideration is that when we are using amiodarone for conversion to sinus rhythm, we should always keep in mind that there is increased risk of embolization if these patients are not properly anticoagulated. Restoration of sinus rhythm that can be accomplished by using drugs or electrical cardioversion. We can accomplish cardioversion using anti-arrhythmic drugs or electrical cardioversion. If the patient is unstable, DC cardioversion is used with 50 to 100 joules biphasic defibrillator. If the patient is stable, cardioversion is accomplished after medical treatment and anticoagulation treatment. Factors that predict a successful cardioversion include left atrial size of less than 4.5 to 5 centimeters, atrial flutter of recent onset with little or no underlying heart failure, and no underlying reversible causes such as hyperthyroidism. If these conditions are met, then we have a pretty high success rate in restoring normal sinus rhythm. Now let's look at anti-arrhythmic agents that can be used for converting the rhythm from atrial flutter to sinus. The drugs included in this category are flecainide, dofetilide, propafenone, ibutalide, and amiodarone. Slowing of the atrial flutter rate with anti-arrhythmic drugs alone can lead to one-to-one ventricular conduction. Hence, before using any one of these anti-arrhythmic drugs for conversion of atrial flutter to sinus rhythm, we should always start these patients on a beta blocker or a calcium channel blocker to block the AV conduction so that we do not end up with one-to-one conduction through the ventricles with these anti-arrhythmic drugs. Let us look at each one of these drugs, their merits and usefulness. The first drug in this category is flecainide, which is marketed as Tambacor in the United States. It is a class 1C drug which slows the slope of the phase 0 of the action potential. One of the drawbacks of flecainide is it has a negative inotropic effect. It is contraindicated in patients with coronary artery disease, structural heart disease, and left ventricular hypertrophy. Flecainide is given orally as 50 mg twice daily up to a maximum of 300 mg per day. Flecainide is not indicated for patients with atrial fibrillation. As I mentioned already, I want to emphasize again that anytime we try antiarrhythmics class 1 or 3, all these patients must be treated with a calcium channel blocker or a beta blocker to block their AV conduction so we do not end up with one-to-one conduction from the atrial flutter. The next drug in this category is the propafenone or Ridmol. It is a class 1C drug which is similar to the flecainide. It decreases the slope of the action potential. It has a mild beta blocking action. It has a mild negative inotropic effect and it can worsen heart failure, so we need to be cautious when we are using in patients with heart failure. The dosage of propafenone is 150 milligrams every 8 hours by mouth. It can create a lupus-like rash and it also has pro-arrhythmia properties. The next drug is the dofetilide, which prolongs the action potential by acting on the potassium channel. This is a class 3 drug just like amiodarone. It is contraindicated in patients with long QT syndrome or if the initial QTc is greater than 440 milliseconds, or if they have a creatinine clearance of less than 20 ml per minute. So there are a lot of limitations when we are talking about dofetilide for rhythm control in patients with atrial flutter or fibrillation. The dose is 500 micrograms twice daily. If the QTc gets greater than 500 milliseconds, we should discontinue the drug. And these patients must be hospitalized and observed for 2 to 3 days before they are continued on the medication. And this drug also has a potential for torsade. Ibutalide is another drug in class 3 antiarrhythmic group. The dose here is 1 milligram over 10 minutes and it has to be given intravenously. If there is no response, the dose can be repeated. However, the success rate is approximately 44% and we need to watch for QT prolongation. This drug can only be given in a hospital setting and only certain people who are trained and qualified can use this drug in controlling rhythm in patients with atrial flutter. Again, this drug also can produce torsade. Now let's talk about the role of anticoagulation in patients with atrial flutter or atrial fibrillation. If the atrial flutter has been in existence for more than 48 hours duration, And these patients must be treated for at least 3 weeks with anticoagulants before any type of cardioversion, either chemical or electrical. And the anticoagulation must be continued for 4 weeks after the cardioversion. Now, if the arrhythmia has been present for more than 48 hours and you need immediate cardioversion because of unstable situation in a patient, then the cardioversion should be performed, followed by initiation of anticoagulants, and they should be continued for at least 4 weeks after the cardioversion. If the atrial flutter has been in existence for less than 48 hours, intravenous heparin or factor 10 direct thrombin inhibitors can be given. The cardioversion is performed, and these anticoagulants are again continued for 4 weeks after the procedure. It is very important to follow these ACC/AHA guidelines as far as anticoagulants are concerned in treating patients with the atrial flutter, whether we are trying to convert their rhythm using drugs or electrical cardioversion. As you know, all anticoagulants have a bleeding tendency. Warfarin is much better compared to aspirin and clopidogrel, and aspirin and clopidogrel combination is better than aspirin in terms of preventing blood clot formation and systemic emboli. This applies to stroke prevention and to bleeding risk. Every atrial flutter patient who is off warfarin for any reason should be maintained on at least aspirin unless there is a contraindication to aspirin therapy. That is, there are times when we have to take these patients off warfarin for any kind of instrumentation or procedure. Then it is important to keep these patients on at least aspirin. There are hundreds of thousands of patients who are on aspirin and warfarin or aspirin and clopidogrel, and they are relatively safe in most situations. Warfarin plus clopidogrel has a relative risk of bleeding which is greater than 3 times that of warfarin alone. And if we were to combine aspirin, warfarin and clopidogrel, the risk of bleeding goes up 5 times higher than if you are just using aspirin and clopidogrel alone. So let me give you a scenario where we may end up using this type of a combination of drugs. Let's say a patient had a stent 1 month ago. So the patient is on aspirin and clopidogrel. Now the patient develops atrial flutter or fibrillation. So you try to add warfarin to prevent blood clot formation, since aspirin and clopidogrel are not very effective in preventing blood clot formations in the presence of atrial flutter or atrial fibrillation. Now these patients are on aspirin, clopidogrel and warfarin. So they are at a much higher risk of developing bleeding. So on one hand, we are trying to prevent clot formation in the atrium and also clot formation in the coronary stent region, but at the same time, we increase the risk of bleeding by 5 times. So in these patients, it is important to reduce the dose of warfarin so that we keep the INR 1.7 and 2.0 instead of 2.5 to 3.5. So by just balancing these medications, we need to get the best results we can under the circumstances. And sometimes these patients may have to be on long-term triple anticoagulant, antiplatelet agents. If that's the case, we should always watch for bleeding signs. Ablation. Let's talk about ablation. Just like in paroxysmal atrial tachycardia, ablation has a pretty high success rate when it comes to atrial flutter. As I said, most of the arrhythmia circulates along the tricuspid annulus in a counterclockwise fashion in patients with type A atrial flutter. It is fairly easy to place a ablation catheter with multiple electrodes, one for monitoring the origin and propagation of the impulse, but also for delivering the radiofrequency waves to break this circuit and thus eliminate atrial flutter for good. The success rate of eliminating type 1 atrial flutter is close to 95%. Ablation is generally performed at 6 or greater positions along the tricuspid isthmus using a catheter like this. Type 2 atrial flutter, the success rate is also close to 95%, but the recurrence rate is more compared to those we see in patients with type 1 atrial flutter. If patients with atrial flutter develop atrial fibrillation, which can happen in almost 50% of the patients, like in one series, it may be necessary to ablate the AB node altogether and insert a pacemaker to prevent rapid ventricular rates associated with this atrial flutter or fibrillation, which can worsen symptoms of heart failure. So in summary, ladies and gentlemen, we talked about the atrial flutter, the types of atrial flutter, type 1 and type 2, the mechanism of atrial flutter. We talked about the atrial rate and ventricular rates. We talked about rate control, rhythm control, ablation, anticoagulation, and much more. I hope this brief summary has been useful to you to give an insight into what atrial flutter is and what we need to do at bedside to control the rate acutely and on a chronic basis. What are the choices available for converting them into sinus rhythm, and the importance of anticoagulation before, during, and after the termination of atrial flutter. Thank you so much for watching this video. Please do subscribe to our YouTube channel and share this with your friends. I am Dr. Nik Nikam, and we will see you next time. Again, thank you so much for your time.